Whenever you're ready.
Ready.
Okay, good morning everybody. I'm Abd Wall. I'm one of the surgery residents here. As you can see over here, you are being videotaped, so anything you say will be heard for millions of people. Today I'm going to talk about abdominal wall reconstruction. Next slide. We're going to start off with some basics today. We're going to talk about how to close the abdomen, both in a basic plan situation as well as in a situation where patient's in dire straits, and also when you do a planned reconstruction, delayed reconstruction. Basically, we're going to, when you do a basic reconstruction, basic closure of the abdomen, we're talking about a fascial closure with interrupted or running suture, and that's basically what you'll see on a normal scheduled abdominal case, and you close the skin with sutures or staples. When you do an advanced, more advanced reconstruction, we're talking about placement of mesh, placement of biologic mesh, rotation flaps, skin grafts, back placement, or separation component, which is plastic surgery reconstruction of the abdominal wall that we'll talk about later on in this lecture. Go ahead. Indications for abdominal wall reconstruction are basically history of abdominal trauma, previous abdominal surgery such as hernia, with or without mesh infection, or tumor, giant abdominal wall tumor resection, including desmoids, dermatosarcomas, as well as other sarcomas. First thing that you want to know is your anatomy, from superficial to deep, from all the way from the skin into the peritoneum. And these are your skin layers. I don't need to go over those today because you should have done that either in your surgical rotation as well as in anatomy as a first-year medical student. What I do want to talk about briefly is the arcuate line. Is David?
Yes.
Go ahead. Tell me what's the arcuate line?
It's about a third of the way between the umbilicus and the pubis, kind of where the inferior epigastrics perforate through. Above it, you're going to have an anterior layer and a posterior, an anterior and a posterior layer. Anterior being external oblique, and the anterior lamina of the internal oblique, and then posteriorly you're going to have the
Transversus abdominis, as well as the other half of the internal oblique. And below it?
Below it, all three kind of come together. The transversus aponeurosis kind of lays above it. Wait, nope, below it.
Okay, next slide. Here we see the anterior, above the arcuate line, the anterior, the external oblique, as well as part of the internal oblique, contribute to the anterior rectus fascia, and you can see the internal oblique splitting here. Posterior part of the fascia, as well as transversus, contribute to the posterior rectus sheath, whereas below, everything contributes to the anterior rectus sheath, and that's important to know for your abdominal anatomy. Basically, what happens when you take a deep breath, when you move, when you Valsalva, etc., causes the diaphragm to descend, and the abdominal muscles are going to contract. You get increased abdominal pressure. This increased pressure is matched by the increased tone of the abdominal wall muscles. Sometimes imbalances occur, and these result in bulges and hernias. Also, folks who are obese, they have increased abdominal tissues, and this is going to increase. This is going to cause a baseline increase in abdominal pressure, as well as the abdominal wall supporting greater weight above the diaphragm, which is going to increase the intensity of your higher pressure.